This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. My name is Matthew Smith, and I'm here today with Dr. Sharif Alozi, and we're excited to sit down with Dr. Russel Samson, Dr. Clifford Sales, and Dr. Ty Garland to discuss how the current COVID-19 pandemic is affecting those in private practice vascular surgery. Dr. Russel Samson is a vascular surgeon in Sarasota, Florida, and is affiliated with Sarasota Memorial Hospital. He received his medical degree from University of Witwatersrand and his general surgery residency and vascular surgery fellowship at Albert Einstein Medical College in New York. Dr. Clifford Sales is a vascular surgeon practicing with Atlantic Medical Group in Morristown Medical Center and Overlook Medical Center in New Jersey. He went to medical school at Mount Sinai in New York and did his general surgery residency and fellowship at Albert Einstein and Montefiore, also in New York. Dr. Ty Garland is a vascular surgeon practicing with Vascular Institute of the Rockies and the director of the vascular surgery at St. Joseph's Hospital in Denver, Colorado. Dr. Garland attended medical school at the University of Washington in Seattle, where he also completed an integrated vascular surgery residency. Welcome, Dr. Russel Samson, Dr. Cliff Sales, and Dr. Ty Garland.
Hi, guys.
Thank you.
So just to get things started off, how are all of you coping? How are your hospitals doing with this COVID-19 pandemic?
Well, I'll start off. Sarasota has one of the more unique population groups in the United States. It is recognized as having the oldest population of any small city in the United States, with an average age of our population being 55, which means that we have a very sizable elderly population who have all run for the hills and are hibernating in their various condominiums and houses throughout the city. The fortunate thing about that is that we are not seeing a huge volume of patients with the virus in our city. We have three main hospitals, but our main hospital is called Sarasota Memorial Hospital. It's an 800-bed hospital that functions both as a community hospital and as a private hospital. And we have, as of this time, only had 12 patients admitted to the hospital, and currently we only have 6 in the hospital at this particular time. So from a point of view of the hospital, we're doing pretty well. Our biggest issue, though, is as a private practice, we have no preventative measures at all. We've been unable to get masks. We've been unable to get hand sanitizer. We can't even get thermometers, and yet we're trying to run a practice.
How about you, Dr. Sales? You're in Northern Jersey. So we are in the process of getting overrun. We are about a 350-bed hospital. We have a 30-unit ICU capacity and the 2 ICUs and 1 CCU, and we're full. You know, I think I likened it to standing on the beach and watching the tidal wave come in and hoping it's going to break before it gets to the shore. But each day it gets closer and closer. Getting up to capacity, that's our focus right now, is the capacity as we move forward, and how are we going to handle it when we get to that point. We've basically stopped most surgeries in the hospital with the thought that we may actually have to use operating rooms as ICU rooms. We've established a line service because all these patients need central lines for pressors, arterial lines for monitoring, and a large number of them need dialysis catheters for their acute kidney injury. So the way we've set it up is with anesthesia, who's been pretty good partners in this. They're the highest risk. When they intubate someone, that's by far the highest risk. So they've kind of delegated that to their most senior people. They go in with the PAPA or the PAPR outfits, and when they're in there, they put the lines in. So they'll do the intubation first, and then they'll put a central and an A line in, which limits the number of touches on the patient. The kidney failure usually comes a couple of days after that, and that's when we'll go in and we'll put the line in for them for the dialysis, a temporary dialysis catheter. That is all well and good if you get an anesthesiologist who could put the line in. There's very few of our anesthesiologists who are not comfortable putting in the central lines. So after the patient gets intubated, we show up and put the lines in. And that's really has not been a problem. So we have not been terribly involved with the management of them. A lot of these patients who are getting dialysis, or not really CVVH, we don't have ECMO in our hospital, but they're getting CVVH. And it's a much higher percentage than we see in a typical sepsis patient. So the thought is there's something about this virus, whether it's cytokine related or not, that has a predilection for the kidney.
How about you, Ty? How have you seen your practice be impacted by the pandemic at this point? You're in Colorado, is that correct?
Yeah, we're in Denver, downtown Denver, covering two separate hospital systems. We're a practice of 6 surgeons that cover about 8 hospitals, both in the city and around the state. And while we haven't seen the same numbers that Dr. Sales is seeing in New Jersey, the tidal wave is not yet coming, although I'm sure it's on its way. We are seeing a very high acuity patient, both with myocarditis and with acute renal failure, in addition to the respiratory symptoms, or even sometimes without the respiratory symptoms. And it does seem to be affecting younger patients. And so that's concerning. As far as the practice goes, we're trying to learn as much as we can from other practices around the country and get ahead of this as much as possible. We've canceled all of our elective cases per the governor's orders in Colorado as of last Friday, but we've kind of had a flurry of activity moving towards rescheduling patients, a month or 2 months out, and onboarding all of our surgeons on telemedicine platforms and training our MAs and office staff on how to get as many patients rescheduled to telemedicine as possible.
How many surgeons in your practice?
Our practice has 6 vascular surgeons, hiring a 7th in August.
Yeah, that's the same size as ours.
And Dr. Garland, what do you see are some of the challenges you guys are going to be facing over the next couple of months with this as patients stay on ventilators? This is going to hit us for a while.
Absolutely. The biggest challenge, I think, is the challenge we're all facing is the pandemic itself, how to keep our workforce and our surgeons healthy and working so that they can continue providing emergency coverage to the hospitals around the city of Denver and around the state that we cover. We've started taking some measures to limit exposures of the surgeons by, like I said, scheduling more patients via telemedicine, limiting office contact, and doing a rotating kind of surgeon of the day or a surgeon of every 2 or 3 days so that we limit the amount of exposure at the hospitals. But I think that's the number one challenge. Next is all the business considerations down the road. How are we maintaining our office workforce and continuing to pay them with reduced hours so that once things come back online, we still have an office and staff and ultrasonographers and PAs to continue to service the backlog of patients that we'll have. Our practice has been together for 20 plus years in Denver, and a lot of our employees are like family to us. So, we're doing everything we can to continue paying them and helping them through this economic downturn that's certainly going to come without furloughing or laying off any of our employees.
So we've got a 15-person practice in New Jersey, 15 docs over 7 hospitals. We've been around for almost 60 years in the community. Clearly, the primary vascular surgery practice in northern New Jersey. And, it's been challenging. We've talked about going to alternating surgeons in terms of having 7 surgeons take the week off and the other surgeons come back and have the self-quarantine to protect ourselves. We haven't really reached that yet. We've talked about it. But what we really have done is we've really tried to limit it so there's only one person in the hospital each day, whether it be a PA or a physician. And we've kind of tried to do that as best we can, since we're really not doing much in the hospital now other than simply putting in lines. And Ty was talking about furloughs and things like that. We've actually started to do that. When we have 5 offices, we've closed a couple of offices, and we've actually furloughed a bunch of people, up to about 15 people now that we've had to furlough. And we've used some of the government initiatives that are at least being talked about, and I'm kind of hopeful that they're going to actually come to fruition, where people really aren't going to lose much salary. What we've committed to is covering their healthcare benefits so they don't lose those. We'll pick up the employee's portion of that we don't usually pick up. So we give them an amount each month, and then they have an overage. We've covered the overage so they all have that. They don't have to worry about that. We've helped people get onto unemployment, so they're getting paid. Some people, family medical leave has been a big thing in trying to provide for our people. I'm not concerned about the long term, and I've told all the people that they're all going to get their jobs back. It's not a matter that we're going to change our business plan. And I think that as vascular surgeons, it's not like a restaurant business where we're going to go out of business if we don't get back in a certain amount of time, that we're going to have a burn rate on capital. We're going to come back. I mean, it's pretty clear that the world is still going to need vascular surgeons, and it's not going to change. The demand won't change. And I don't think the supply will change either in vascular surgery.
How about you, Dr. Samson? Have you had to deal with any staffing issues?
Well, as I said, we have 6 doctors, 2 physicians. We have currently 7 vascular lab technicians. We run a very big, busy outpatient angio suite that has maybe 10 or 12 staff members down there as well. So currently what we're doing is we've broken our workforce into teams so that if one team gets sick, we can still continue with the others. And we have sent some of the people home, and they're all working with us, just doing things that they can do from home. Things that we've had on the back burner, like evaluating social media, our internet, other things that we can have them working on. We're trying to guarantee that everybody at least will be employed for as long as we can. But our practice has an enormous overhead, and if a number of the doctors go down, it would have a tremendous hit to the finances of our group. And then perhaps we would have to curtail some of our office staff. It's something that has to be taken into consideration. And especially in our town, when you think about our town, our practice is really vascular surgery in Sarasota. There are 2 other vascular surgeons in our town. But if our practice suffers where our doctors are out of commission in vascular surgery, even emergencies will have to be shipped out of Sarasota.
All of you have mentioned that you're not really doing much in the hospital for obvious reasons. Are any of you associated with outpatient angio suites or OBLs that you are still doing procedures in?
Well, I think that's what I mentioned. We have our own outpatient center. In fact, we probably had one of the first in the country. And we are still doing some procedures in that area, but obviously we're not doing anything that is anything other than life or limb salvaging. We certainly do some of the dialysis procedures to keep people on dialysis to maintain fistulas. We'll do procedures for limb salvage, but we're not doing claudicants or anything like that. In Florida, too, we have a government mandate that we're not allowed to do anything that's non-emergent, even in the office.
It's similar in Colorado. We have been working in an outpatient lab for a number of months now with some of our cardiology colleagues, and that's all come to a halt at this point for us. We had reserved that for primarily very safe elective outpatient procedures, and it's been pretty clear from our governor that those are to come to a halt. So that revenue stream is no longer moving forward, at least for the next month or 2.
So you mentioned that you're making adjustments to the call schedule, particularly with trying to keep it a week on, week off, and limit the exposure of the staff to the vascular surgeons getting sick. Have you guys made any considerations for partners with perhaps medical comorbidities, or dare I say older partners who may be more at risk for infection than younger partners? Have you guys adjusted for that?
So I'm the oldest in the practice. I shouldn't even be in the practice anymore. I'm in the practice because we're so short-staffed in this area. It would be a problem if I'm not around. But I am limiting myself not going to the hospital because not only am I older, I do have some underlying comorbidities. But other than that,
okay.
So we have a partner who just had a baby.
Yes, I know. Congratulations to Dan.
Actually told him.
Yes.
Right. So we've basically told him to stay away, just stay home with the kid until this thing rides itself out, and he'll do some telemedicine for us at home, but it's just not worth it. And quite honestly, we don't need every hand on board here for this. We can do without it because the volume is down, so there's no reason to put someone at risk.
How about you, Ty?
Primarily in the same boat. We have one older partner who's continuing to do telemedicine, and we've encouraged him to not go to the hospital and not put himself at risk. But at the end of the day, surgeons will be surgeons, and we all want to pitch in and help. So it's trying to limit that exposure and keep him busy in other ways so that he feels like he's productive and pulling his weight.
It is interesting. You say surgeons will be surgeons. It's in times like this, you see the best and the worst of people. But it really is interesting that almost everyone to a person has really wanted to step up and they say, what can I do? I mean, I'll do anything. I mean, I've got docs and our PAs are acting as nurses in our procedure suite because some of the nurses have gone down. And they'll just go there. They'll do the paperwork, do whatever they have to do. It really has been kind of interesting to see that. I'm sure you guys are seeing it too, because the worst thing for a surgeon is to be inactive.
Absolutely. And we're seeing the same thing. We've even come up with contingency plans for our surgeons because the hospitals are already putting together backup rosters for managers in the ICU to manage vents and put in lines and things like you've already been describing, Dr. Sales. And so we're trying to figure out what happens to our call schedule if we have one or two surgeons volunteering at a hospital running an ICU. So those contingency plans, while still not fully formed, are already being talked about.
So I was asking the other guys in practice, are you having as much trouble as we are in getting protective gear?
We haven't had a problem.
We're not. I told the administration, and we spoke with the administration and said the one thing that we need from them more than anything is their assurance that we're going to be safe. And I said, our guys, they're scared, but they're willing. Sharif, you know Mike Addis, who was an Army Rangers lieutenant, and he said, he was in the first Iraq War, and he tells me, he said, when we went out into the desert to fight the Iraqis, I used to turn to my people and say, if you're not scared, you're stupid. And that's the same thing here. And I really tried to impart that. You just got to be careful, and you got to be smart. And I think that's kind of it. Those of us who are old enough remember back in the 80s when every single patient who was having crazy infections got a lymph node biopsy to make a diagnosis of HIV. It wasn't called HIV back then, but it was the same thing. It was a little different because we weren't worrying about airborne. You'd go into the OR as an intern and you were petrified about getting stuck. No one understood about it, and similar to here.
Yeah, but I'm not interested so much in the hospital because I think that's something that goes across all lines, not only community practice but academics. But I'm interested in what you're doing in your office. What are you doing in your office to arrange the flow of patients and to protect your staff?
Well, we've tried to space out the appointments. We have blocked off every other chair in the waiting room. The staff wear masks. I don't think there's any value to that, but it does make them feel better. We've encouraged everybody who wants to take off. They want to take a leave. They've been encouraged to do it and not worry about their jobs, that they will get their jobs back. I went and I spoke to every single employee. We have 100 employees. I spent every single one of them individually and reassured them that we are here to protect them. And whatever they want to do, we'll support. And a lot of them have taken leave. A lot of them have children, so they go home. They have to watch their kids. They don't have the ability to have some childcare. So we've made it very easy for them to do whatever they want to do and whatever they need to do.
Do you take the temperatures before patients come into the office?
We do. Well, we take the temperature of all the staff before they come in. The patients, we ask them. They go through the whole rigmarole where they've been and the exposures and things like that. We have not been taking temperatures of every patient. If someone says they feel feverish, we'll basically send them home. We try not to see them. The problem is patients don't always tell you the truth. If they want to be seen, they're going to be seen. And we try to limit the number of, we tell them we don't want visitors. But, when grandma comes in and she wants her daughter in with her, it's kind of hard to say, no, she can't come in. We will have the patients wait in the cars in some of our offices that are a little bit more crowded, and we'll call them to come in when we're ready for them if there's a delay.
So we have a nurse stationed outside taking their temperatures and doing a full questionnaire on them as to whether they've traveled or where they've been and any potential conflict. We've only allowed 3 people into the waiting room at any one time. We've actually staggered chairs outside the waiting area. We even take the temperature of our doctors and staff coming into the office. But the downside, as I mentioned, specifically here in Florida and speaking to other practitioners in Florida, we have no ability to get any protective gear. I mean, the only things that we have are surgical masks that we are taking out of the hospital, and even those we're not taking out because they need them there because they don't even have the new N95 masks. So, I mean, I think for some reason, from what I can gather, the government is sending most of its protective gear to areas of high impact, such as New York and Washington and other areas. We're just not getting it.
Interesting.
So, speaking of hospital administration, how has your interaction been with the hospital administrations where you have inpatient privileges? How has it changed with the impact of the pandemic?
Well, as far as ours is concerned, we had a very good relationship with them, so there hasn't been an issue. But the one thing that I think is important, and this was brought up by one of our more younger partners, is to point out to the hospital that a lot of our endovascular procedures, which are still going on in the hospital, certainly the emergency ones, are dependent on having techs that know how to use the machines. And we've tried to get the hospital to understand that they need to stagger those people as well. Because if those techs go down, we won't be able to do some of these procedures. That was brought up by Jason Wagner as one of our new hires.
How about you, Cliff? You're a little farther along in the curve.
Yeah, it's been interesting. I think what we've seen is the administration, the so-called suits, much more so than I've seen in 25 years, taking a bit of a back seat to the clinical folks. The chief medical officer and some of the people who have dealt with patients. And they've been pretty supportive as to what's needed, kind of opening up their bank books a little bit more than they usually do, kind of being a little bit more responsive to the physician's needs than I think that they usually are. So it's been interesting. They certainly haven't been the roadblock that sometimes the physicians perceive administrators to be in this crisis.
On the same line as the radiology technicians, a lot of the procedures we do obviously require vendors to come in and out, but our hospitals are locked off to one entrance with no visitors. Are you guys having any problems with that?
Right. No, none.
Well, our hospital is still letting the vendor, if you will, come in, and we still have for example, on endografts, if they have to be performed certainly on an emergency basis, they are allowing the relevant rep to come into the hospital.
What have you guys done with your vascular labs in the hospital?
Are you asking us? Because we've shut down our vascular lab, but I think our hospital is at a level where basically we're only doing emergent vascular cases like a ruptured aneurysm, a symptomatic carotid, CLTI cases we're not doing if it's a small ulcer or something like that. And so we've decided that our vascular lab, the outpatient vascular lab, there aren't really many emergent studies that need to be done aside from maybe a DVT study, and that can be done in the hospital. And even some of those cases, we'll just send a D-dimer level and presumptively start heparin,
But what about your in-hospital labs? I mean, are you guys involved with running them or having anything to do with them?
So we do inpatient studies, but there is also radiology available. So we've decided that in order to protect our techs and minimize the number of studies, we'll just rely on radiology for the venous studies. But I think, again, New York is farther along than any of your sites. Right. It's all hands on deck as far as only treating coronavirus patients now. So, Dr. Samson, you were saying?
So, I mean, it's a little difficult for us to compare what's going on here to the rest. As I can hear, we just don't have the high volume yet. But we have a very elderly population, as I said before, and our elderly population is going to go on getting the same diseases that they've had before. So, our vascular lab in the hospital, which is run predominantly by vascular surgery, is continuing, but we're trying to do the same thing with our techs so that we don't find that our techs are all leaving or having to be put on quarantine. So they're basically going some on, some off, and reducing the number of tests as much as we can. But the requests for tests will come in just like they used to.
Yeah,
it's interesting because what we've done is we've gone to basically any test that a COVID patient needs has to be approved by the chief of vascular, which is amazing. So I look at every single request, and it's amazing how quickly they went down to almost zero. Because you're exactly right. I want to protect our techs and to bring a machine in. We have a laptop that we use for our lines, and you can use that just fine to do a rule out DVT study. And the question that I ask, every time is, if you get a positive study, what are you going to do? How is it going to change your management? And if it's simply, we'll put the patient on anticoagulation, because we're starting to see some peripheral thromboses in this, both arterial and venous. I say, what's the downside of putting them on heparin now? Just put them on anticoagulant and see. Because the risk is probably less than sending in a tech to go into 6 out of the 10 rooms and move a machine between them. It's very, very, very high. And we've really taken that seriously.
And cleaning the machine between studies is not trivial for contamination with coronavirus.
It's huge. Yeah. Because those machines, they have fans on them that suck in and blow out. So it really does increase the risk to everyone. So they've literally gone down to zero. We have not had any tests in the last 72 hours that we've done.
That type of recommendation might actually be very helpful for the SVS to put out, hospital-wide.
You clearly have an enormous experience over there, and that's what we're seeing coming out from other centers. It's just a tragic event.
I think you have to be scared.
Have you guys all shifted your outpatient office? Were you doing telemedicine before? If not, have you shifted to trying to do more telemedicine now? What are you doing to adapt to that?
In Colorado, we were a little bit ahead of the curve, I think, because we serve a pretty large, region from the Western Slope and Eastern Utah all the way up into Wyoming. And so we had somewhat of a telemedicine operation going, but now we've been able to onboard the rest of our surgeons. So last week, we saw 2 full clinics via telemedicine, and this week, all of our surgeons at least have telemedicine offerings within their clinics. And I think everybody's been pretty pleasantly surprised. I think I had about 70% of my clinic that I saw via telemedicine last Friday, and it was overall very successful. We're using a platform called Doxy.me. There's another platform that's local in Colorado called Hippo Health that we're looking into a larger partnership. It's a telemedicine platform that's integrated with a local physician network of primary care providers and specialists. And so we're looking at this also as trying to find the silver lining and figure out how we can build on this to increase our regional throw and our regional impact even after the COVID pandemic. So I had a patient who's 92 years old who I saw via telemedicine for an endo leak last Friday, and he logged on without any problem, and I was able to share my screen and explain what an endo leak was and get him scheduled for an embolization sometime in the summer. So it's been pretty impressive what people step up for.
That's great. How about you, Dr. Samson? Have you guys been embracing telemedicine yet or no?
No, we just started. We started this week when it got approved financially by the government. It's been somewhat difficult with some of our elderly patients, but some of them are adapting very well. So we use Doxy.me. Some people are using their cell phones. Some people are using Skype. We're using all forms. It seems to be working quite well.
Well, like someone was describing earlier, a lot of these patients want their daughter or son or loved one to come to their appointments with them, and they're equally willing to drive over to their parents' house or somehow help them with their telemedicine connectivity. So that's been very helpful.
Cliff, how about you guys?
We started telemedicine a while ago. We never really got it off the ground as we were using the VC platform, VSCE. And then this week, with the relaxation of a lot of the rules, particularly the site of service and things, we started doing it again. Quite honestly, beforehand, it wasn't financially really rewarding. It was, a 10-minute interaction was something like $17. It was like, 20 minutes was $34. It didn't really make a lot of sense for us to do that. And, in the Northeast, people drive and it's close. I mean, everything is close. So we're all squished in together. So we didn't really have a great telemedicine practice. I think in the last 2 weeks, we've opened it up again. But quite honestly, it's really been phone calls. We just do it, talk to the patients, try to talk them off the ledge or get them comfortable and kind of reassure them. We don't even bother charging them and just get them along just so they can get over this. A couple of people have results pending of their studies that have been done. We talk to them about it. So I wouldn't say we've been a huge adopter of that technology.
I think our experience with it now, I think is good enough that we're going to keep it going. If the government allows us to keep the funding for telemedicine, I think we're going to utilize it more.
Yeah, absolutely.
Yeah, absolutely. I think it will eventually come down to the payers and to Medicare after the pandemic ends, but patients certainly love it, especially. I mean, it's interesting to hear Dr. Sales describe the regional variation. For us, patients absolutely love it. I have, a large fenestrated endograft practice and get patients from all over Wyoming and Utah. And the last thing they want to do is figure out how to get a ride for 8 hours from Casper to Denver so that I can review their CT scan with them. So this has really helped us even before the pandemic, do preoperative consultations and things and plug patients into the system before, they make the drive for their operation.
Yeah, it's a great help for reporting vascular layers.
Aside from the healthcare aspects of this, do any of you have any concerns about the business side of this? The cash flow or rent?
Well, I think right now, most vascular surgery practices are just fine. It's in 2 weeks where it's going to hit. I think if you're not making plans for that now, you're going to be in trouble because, we're generally, most of us have over 70%. If you're just doing vascular, over 70% of our business is Medicare, right? So it's basically a 2-week delay. So the billing has been okay up until last week, and then it's been starting to plummet, and it's going to plummet further. So you carry that out for 2-3 weeks now, and you're going to start to see a real tough time making payroll. There's no doubt that that's going to be tough. Those of us who own our own centers can kind of work that a little bit because if we're paying rent ourselves, we can kind of delay that rent. But I think you've got to look at cutting all the costs you can right now, going to the vendors and say, listen, you got to have to understand those 30-day, net 30s are going to have to turn into net 90s, maybe net 120s without penalties. And I think we're going to see who our friends are. And that's going to carry forward for the long haul.
How about you, Dr. Samson? What are your thoughts on that?
I think any private practice physician at the moment is potentially in trouble. And the overhead that we run in our practice is enormous. And this decreasing the work that we do across our vascular lab, across our angio suite, will take a tremendous hit. And I'm hopeful that we will be regarded as a small business, just like any other small business. And I know there have been overtures made to the government from a number of different organizations in medicine to help protect the community practice physicians, because this is going to make a tremendous hit to the bottom line. And I think that many practices are going to go broke. It's just impossible to run a modern community practice with small volume.
Dr. Sales, you mentioned something about the possible legislation they have for relief, and Dr. Samson as well. Do you guys have any insight into resources that distressed practices can appeal to from the government?
Well, I think you have to wait. You have to wait for today's package to be finalized and signed and put into law so we can read it. You certainly can go on your state website because you've got people here from a bunch of different states, and the rules are different by states. The unemployment laws and the FMLA and disability laws are different per state. I think whatever the stimulus, they've been talking about tax credits for continuing to pay your employees. I think that those rules are just getting hammered out. Listen, I guess our government could figure out a way to piss away $2 trillion without giving it to doctors. But I think there's got to be some money in there for employees who are hurting. We're hurting from this. I'm sure you guys are all the same. Most of our employees are young women, high school educated, locally graduated. Some have been working for a long time, but still the same, who live basically from paycheck to paycheck. And even an interruption of a week could be catastrophic.
The important thing is, from what I've understood, is to keep our employees employed. As long as you maintain their salaries, there's a high chance that there will be some remuneration coming back to the small business, even the medical practice. I know there's an organization of medical coders and billers and people that run medical practices that have already put out a letter to the government asking for support for medical practices. So I have every reason to hope that they will pay attention to it. But in the meantime, the thing is to take lines of credit and be ready to cut back on your own spending in your own environment, in your own home life, and to be very fiscally responsible. I can assure you that in the next month or so, you will see practices going broke.
Ty, you were about to say something?
I was going to say that's my understanding as well, Dr. Samson, is that the most important thing to qualify for these assistance programs is to keep your employees employed and to not be laying people off and to continue paying some sort of salary to them. We've already been in contact with our local banks and it looks like the SBA disaster program, I don't know how it varies from state to state, but it's approved in the state of Colorado already. Like you said, how exactly these are going to be administered still is determined by the bill that hopefully will be signed this evening or tomorrow. But they're already taking applications through some of our local banks. So you could reach out and try to get ahead of it like that. But we're also hopeful that if we qualify for some of these SBA assistance or disaster assistance programs and loans, that eventually these may be forgiven if we're able to keep our employees employed. So it's a little bit of hope, but I agree. We've been having emergency meetings about every 2 or 3 days to look at cost containment strategies. Where can we cut on equipment? Where can we cut on supplies? How can we cut down, on hours and overtime, just to try to really tighten up the budget as much as possible for the next few months so we can weather the slump in May and June when our AR slows down.
This has been great, guys. Is there anything else that we haven't touched on that, that might be a particular concern to you that we might not be seeing as we, sit in a large academic institution?
Well, I can say just one other thing that we've noticed. Again, because we don't have the high incidence in Sarasota, we have noticed that some of our younger staff are not taking social distancing to heart in the same way that we think they should. For example, some of our staff recently had a birthday party and had multiple people attend. And we pointed out to them that if we find out that they are not behaving socially responsible, or we find out through Facebook or some other evidence that people are not following the rules, that we would have them terminated. The only people that we've really threatened with termination are people that are not following the line.
Did you think that sunk in? The severity of that sunk in with them?
Yes, it's fascinating how some people really are scared, and then there are other people that still think that this is some type of hoax, even though they work in the medical profession.
Yeah,
it depends on the demographics of your political affiliation in the cities in which you live, and perhaps in this town, people are watching the wrong networks.
Ty, you were about to say something?
Oh, we see the exact same thing in Colorado. It's amazing that, in the city of Denver, people seem to be starting to take it more seriously and following the stay-at-home orders, executive orders by the governor that went into effect last night. Although I've been contacting some of our colleagues around the state who tend to live in different political realities, and there's a lot of misinformation about the virus and about it being a hoax and about it not being serious and not affecting younger people. So I've been trying to share as many actual medical resources with our staff and with the staff around the state to show them that this is the real deal. I firmly believe we're 2 to 2.5 weeks behind in our diagnosis and our estimates of any of the numbers, and that the tidal wave is coming. And these stories, like this patient that's in our ICU right now, who's 32 and vented and proned without any previous medical comorbidities, should scare everybody. There's a lot we don't understand.
I think the important thing is, as the leader in your practice, you don't want to be up there waving the flag and either scaring people or, falsely reassuring them. I think that what I've tried to do is to try to be as factual as I can to people and try to get the information and get them to the CDC website, get them away from CNN.com and FoxNews.com and all this stuff where they're getting misinformation. And, we've all seen the articles on Facebook, and a friend said, no, is this true? Is that true? Can I do this? And you just try to stay factual and just try to reassure people that we're going to get through this. We will get through this. It's a disaster of unbelievable proportions, but we're going to get to the end of it, and hopefully we'll learn something from it. Whether we do or not, we'll see. But I think that's been the biggest challenge for me. And quite honestly, it's the docs too. You have to keep your docs focused, and your docs. We've got a couple of docs who are really very. They're off the deep end. I mean, they're focused on their 401ks, and they were kind of looking and then planning where they were going to do. And now they see, they just dropped 20% or 30% or whatever it's been. And I think it's important to keep people with their eye on the ball and we've just focused on taking care of our patients. And it's, as I was saying before, that the good and the bad come out. You just focus on taking care of your patients, because that's why most of us went into this. And when times like this come back, you get back to your roots and think, this is why I did it. This is why I did it. I'm trying to help these patients get better. And you focus your staff on that. The staff doesn't realize a lot of times what you do and what they do. And if you can just reassure them that they are there for the patients, it helps with their approach. It's helped our staff.
I think that's a good message. The idea that cooler heads will prevail. I mean, it's a very serious moment. There are also a lot of rumors going around, and we talked about this in our last interview when we were interviewing Mal Sheehan and Ben Starnes and saying about their experience, and they all emphasized that you don't want to sort of give life to these rumors, and being as factual and evidence-based as possible is sort of our role. I mean, we are doctors, and you can take a leadership role in the community, and I think that's good what you said, that Cliff.
Yeah, and the other thing is the good news with the stock market falling through the floor is a lot of older vascular surgeons that were burnt out and were ready to retire are going to stay on for another 15 years.
Yeah.
So you won't have a shortage of vascular surgeons in the future.
Right.
And hopefully we won't have a shortage of patients.
So we want to ask maybe one sort of final question. I mean, this has been fantastic, but we don't want it to be all doom and gloom. Are there things that you guys are hopeful about in terms of the way we're responding to the epidemic, or are there things that maybe we can learn from and gain from this experience? And you can take your time and think about this. I know it's sort of putting you on the spot.
Well, I've been impressed at how much the community does come together, at how much everyone's willing to pitch in and help in the time of crisis. I think that's something that's kind of unique to, or at least demonstrated in Americans, and I think that this is no exception. I'm hopeful that if we continue to take things seriously in the social distancing protocols, we will see an earlier peak, or at least a more flattened peak than some of the models show. And I think we're making good progress towards that. And like I said earlier, I think this is a good opportunity for us to try to find the silver lining, to try to figure out how we can use telemedicine to better reach our patients, and to try to ramp up infection protocols and things and response teams around our hospitals. So hopefully we'll all learn some good lessons from that and end up being able to better take care of patients in the future. It's going to be a rough couple months, but I know we can all make it through it, and I think come out better in the end.
I think that was beautifully said, to tell you the truth. I can't add anything to it other than the fact that I'm hopeful that we've learned a tremendous lesson with this epidemic that will help us prevent future epidemics in the future. I'd hate to think of my children and grandchildren going through this, and that I'm hopeful that the country and the world has learned.
Cliff, any thoughts?
No, not really. I mean, it's a shocking phenomenon what's going on. I think we need to understand the why when we get through with this, and then maybe we can figure out the how, or how to avoid. It's unclear as to why this happened and how this could have happened, and I think that this is going to be one of those things that's analogous to the Kennedy assassination, that we're going to see lots and lots of literature and stories about conspiracy theories and the like, international, national, local, political, apolitical. And I'm not sure we're ever going to know, but I would hope that as a scientific community, we can understand why this happened and how we could ever prevent this from happening again, something like this, because it's devastating. It's devastating on a personal level, obviously on a medical level, when you see young patients dying in large numbers, and clearly on an economic level for society. So it's tragic.
Well, I hate to be an opposite view, but Bill Gates did a TED Talk 5 years ago that predicted this whole thing, gave the reasons for it and the answers as to how we could have prevented it. And despite the fact that we had a man that gave us so much in the computing industry and that changed the world, nobody listened to him. The fact that we're suffering through this at this stage is an indictment on politicians and the world at large.
Yeah. Well, hopefully we learn from this.
Well, thank you all once again. This has been an excellent discussion. I know many of our listeners who are out in situations like yours will find this interesting and helpful. I appreciate all of your time.
Yeah, no, thank you very much. We really appreciate you guys taking the time to speak to us about this.
Yeah, we all learn from this.
Absolutely.